Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I want to talk about muscle imbalances and treating pain. This might be basic for people who already know motor point acupuncture, trigger point dry needling, etc. But I wanted to kind of go back to the basics on some of this stuff because not everybody is aware of the underlying assessment and treatment, paradigm that we use for treating pain. In fact, I would say that actually the way I treat pain is different from the way many orthopedic acupuncturists treat pain, because I'm actually not treating pain. I believe a lot of acupuncturists are focusing on pain and trying to treat pain with things like electric stimulation for neuromodulation. I come very strongly out of the world of the Prague School doctors, Vladimir Janda, Karl Levitt, who would have said they were not actually treating your pain. They were restoring joint function. If you can restore the normal range of motion to a joint, the pain will be resolved. So I want to talk about that. It's important because I kind of take it as for granted that I'm not really treating pain. I'm treating dysfunction. Even for a nerve entrapment scenario, you're still not treating the nerve pain, numbness, etc. You're treating either the muscular fiber dysfunction or the tonicity of a muscle that is putting pressure on a nerve. You're still treating the dysfunctional muscles in order to relieve pain. And it's the same for joint pain. Our medical world looks at joint pain as being caused by something like arthritis or tendonitis or micro tears, micro trauma. And I want to say, I'm not talking about traumatic injury right now. Okay. That's a different discussion. I don't want to talk about that. I want to talk about the normal joint pain that people get from being active, from aging, from overuse, from just living a life as a human being and getting to live past 35 or 40 years old. You will encounter pain that you did not expect and that you cannot explain. So this is what I'm really talking about. Back pain, neck pain, shoulder pain, etc. You're just doing your normal thing and now you have pain. So if we look at it from the Western medical world, your pain is being caused by inflammation. Your elbow pain, your knee pain is being caused by inflammation. The stress, strain on the joint. They'll talk about bone on bone for someone with osteoarthritis. Tendinopathies, you can do an MRI or an X-ray, you might see inflammation. So, but the pain is not, the inflammation does cause pain. The source of the problem is not the inflammation. Your painful knees are not ibuprofen deficient. Your knees don't hurt because of a deficiency of corticosteroids. That's just a way to treat your pain. And treating pain is really not very satisfying because the pain will always come back. If you're not treating the problem, you're just treating the symptoms, the pain will come back. In my world, I'm trying to do better than that, not just treat the pain, but the source of the problem. In many cases, the source of joint pain or even nerve entrapments is postural issues caused by muscle imbalances. If you think about how a joint works, the joint needs muscles to cross it and attach on the other side of the joint, usually the tendon, right at the other side most of the time, in order to function. So the quadricep muscles cross the knee joint and attach on the other side. The middle quadricep, which is called rectus femoris, is also a hip flexor because at its origin, it is above where the hip joint is. So since it crosses the hip joint, it can assist on hip flexion. So that's how joints work, okay? That might seem ridiculously simple for me to say that, but if I didn't say it, there are a lot of people out there who never really took the time to sort of visualize the mechanics of a joint. Because if your doctor talks to you about your joint, they're just talking about the bones and the ligaments and the soft tissue. They're really not talking about the muscles that make the joint function. When I talk about your knee, I'm thinking about quads and hamstrings and IT band and adductors. And even gastrocnemius. I'm not thinking about the actual joint itself. My ability to help an inflamed arthritic joint comes from correcting the muscle imbalances that have caused rubbing, a lack of centration, weakened stabilizers, things that led to the opathies and itises and arthritis. So I'm not actually trying to treat arthritis. I'm not actually trying to treat tendinitis, bursitis, tendinopathy, tendinosis. I'm saying, what is wrong with this joint function that is causing bursitis, tendinitis, tendinopathy, arthritis? Why is the arthritis happening? If it was some sort of virus that you caught, there would be an antibiotic or there'd be an antiviral drug, and we would just knock out arthritis, right? It's not like that. The arthritis or the tendinitis or the joint pain in general is being caused by the movement of the joint not being normal. So muscle imbalances. An imbalance is where some muscles are too tight and short and others are too weak to stabilize. And by the way, the tight, short ones are also weak. So you have a problem where repetitive movement is causing rubbing. It could be rubbing of a bursa. It could be rubbing of a tendon. It could be the joint rubbing, causing soft tissue deterioration. We need to figure out how to correct the movement of the joint in order to relieve the pain and the inflammation. If I thought I needed to treat your knee pain, I would be sticking needles into the knee joint and maybe putting electric stimulation. And electric stimulation is really good at blocking pain. This is why people have surgical implants of spinal cord stimulators, because electric stimulation can block pain signaling, but it doesn't fix the problem. So, you stick those needles in someone's knee and maybe they feel better for a while. All you're doing is pushing them toward a knee replacement in the future because you have not corrected the problem that will deteriorate the joint further and lead to a point where it just doesn't even make sense to not have a surgery. when we can assess the joint function and improve, release muscular dysfunction, muscle fiber dysfunction, where the muscles have gotten too tight and weak, too short. If we can correct that, we get the blood circulating, we get better nerve function, we get the muscle firing better, it's stronger, it's more flexible, in every way healthier. You're going to allow the joint to move properly, and there will no longer be inflammation and pain. This is every joint in the body can be addressed with this simple concept. And unfortunately, there's still a lot of people trying to treat the pain. And I get it. No one wants to be in pain, and we want our patients to not be in pain. But the 2 steps back that led to the pain is what we should be treating. Okay? I say 2 steps because the pain is very likely because of an inflammation in the tendon, some edema, some swelling, fluid accumulation in the joint. There are a lot of things that go on when there's a dysfunction of the joint. Though that's 1 step back. Now you need to go the step before that and say, how did this happen? Why is this joint rubbing? And why is it only the right side and not the left side? It's not systemic. It's very likely not coming from a major compression at the spine. When you have a bilateral problem, sometimes you do want to look at the spine, okay? On most people, there's going to be some compression at L4 and 5, okay? So have at it. Always consider that, but you can't just treat L4, 5 for knee pain. You just can't, because by the time they're having knee pain, the muscles have already contracted. They've already shortened. They've already become weak. They've already become inhibited. So fixing whatever's going on at the lumbar area is nice, but it's not the answer. This is why so many times I'm seeing people who have already had the knee replacement surgery and they're still in pain. The reason almost always is that the same imbalances that led them to a knee replacement surgery are still there once they reattach the muscles. You can take that joint out, put in a great mechanical joint replacement. I don't care how beautiful it is and how perfect and how great your surgeon was. If your quadriceps were already too tight, your IT band was tight, and your hip stabilizers were weak, your adductors were tight, you're still walking around with a dysfunctional movement pattern that's going to give you pain and inflammation. So you still have a problem. And, sometimes those surgeries can increase the muscle shortening and the muscle inhibition. There's plenty of studies on arthrogenic muscle inhibition caused by a surgery, like an ACL surgery or a knee replacement. So it's a known thing. There's plenty of research on it. So you have that on top of the muscle imbalances that caused you to have a knee replacement. So, and you can't just work on the things across the knee, by the way. You have to think about the whole hip. You got to think about the ankles, because all of those things are working together to give you a movement pattern that will not cause dysfunctional rubbing and edema, etc. Okay, so you got to correct the whole movement pattern, and really it could be everything from the pelvis down. So, and that's stuff that I've talked about before in other episodes. I'm not going to go into it too much. But I think it's important for people who are new to orthopedic acupuncture or sports acupuncture, whatever you want to call it, that you're really not treating pain. There are methodologies in Chinese medicine, especially, the Tan Balance and Master Tongue that are doing some sort of, was it like gate theory to block pain? If you stimulate the fascia and you stimulate, or maybe you're pecking on the bone at the periosteum, you're sending signals that can override the pain. So in some methodologies, you can block pain temporarily with Chinese acupuncture. And if that's all their patient wants, and if maybe they have really good insurance that's always going to cover them coming in once or twice a week for a long period of time, that might be all they need to get past a period of inflammation that will heal them enough that they can be mildly active. But you haven't fixed the problem. It's still there. When we have dysfunctional movement that is being caused by trigger points in the muscle, short, taut bands in the muscle, that's another muscle fiber dysfunction. You could have a flare-up of a trigger point where the person's in a lot of pain for weeks, and then they get a reprieve. The inflammation clears. Maybe they've stopped being active. The inflammation clears. They feel like they're back to their normal self. But those taut bands are still there. The dysfunction is still there. So when they go back to maybe running or cycling or whatever it is they like to do, playing tennis, those taut bands are waiting to get irritated again and cause pain again. And it's going to cause pain into a myofascial pattern that is going to be related to the joint and the fascia. So taut bands in the muscle are causing dysfunction in the joint and muscle, and they need to be addressed. And in those cases, you're going to need to dry needle those taut bands. You're going to hyper irritate the taut bands, make them quickly twitch, release. They release the pain chemicals. They become healthier muscle within a week or two, and they become more flexible, more elastic, stronger, and they give your joint better mobility. And that's the key. Correct the joint mobility. And it doesn't have to be the textbook range of motion, the goniometer reading that you get from your textbook, especially if your patients are older. You really just need to get it more functional than it is right now, hopefully back to the function they had when they weren't in pain. When it's one side, you can usually compare the range of motion on the other side to see what their normal is. For instance, you might see somebody with very little hip internal rotation because their external rotators are so tight, but the only one side's causing pain, and that's usually less hip internal rotation than the non-pain side. So you're really just trying to get back to what is their normal. Now, I'm going to suggest if they're coming back for more than a couple sessions, start treating bilaterally and really fix both sides. Give them really good hip internal rotation by working on those deep rotators. I mean, why not? I feel the same way about anterior pelvic tilt. You know, it's the problem for one side that has sciatica, but of course you're going to treat the psoas on both sides, the TFL on both sides, the rectus femoris on both sides. You want to get that anterior pelvic tilt minimized, not only to get them out of pain and relieve sciatica, etc., but because quality of life relies on mobility. We all feel better when we're more mobile, when we have better mobility. We're less stiff, we're less tight. A lot of the pains that people have only in the morning are musculoskeletal origin, and then once those muscles warm up, they have less pain, they feel more mobile, they can kind of get through their day. But it's no way to live, to wake up in pain every day, to wake up dreading having to stand up or to stand for more than a couple minutes to shave or shower or whatever. No one should have to live like that, and they don't. correct the muscle imbalances that are causing pain and dysfunction. So I wanted to kind of put it out there. This is why you should really study your Yanda cross patterns, because it gives you a lot of information about the muscles that are prone to shortening and tightening, the muscles that are prone to weakness and inhibition. And it's just going to give you a really good understanding of what happens to the body as we age, because those cross patterns were developed when Dr. Yanda would see people with cerebral palsy who had an extreme version of these cross patterns. And what he learned from the cerebral palsy patients was that this was a pattern that he could see in small degrees on people without cerebral palsy. And this is where he recognized that there were tonic muscles and phasic muscles. The tonic were more slow twitch, prone to shortening and tightening, and the phasic muscles were more fast twitch fibers and power muscles that were more prone to fatigue. And that's where he developed his cross patterns. So when you understand his upper cross and lower cross patterns, you already know the muscles that are prone to shortening, and you know the muscles that are prone to weakness. And if you look at reciprocal inhibition, you're really on a good track to help somebody with their mobility and pain. The tight muscles, or the tonic muscles, are more likely going to be the ones that cause the joint dysfunction and rubbing that is causing pain. Of course, the phasic muscles eventually need to be treated, because their weakness, their inhibition, is likely the reason that the tonic muscles were overworked and got tighter and shorter and pulled more on the joints and tendons and caused inflammation, tendinitis, arthritis, etc. So we're not really treating pain. We're treating joint dysfunction. We're treating mobility. We're treating pelvic tilt or scapular tilt or forward head placement. We're treating the things that happen to everybody that have gone just a little too far and are now causing dysfunctional pain, or dysfunction and pain, I should say. So I wanted to put it out there. I don't think most people put it that way. I think a lot of people really focus on treating pain and blame it all on the spine, and they're really gonna try to neuromodulate the pain and treat the root of it being the spine, as opposed to the root of it being muscle imbalances. So that's where I differ. And the spine, absolutely, I'm willing to admit that slight compression of the nerves is very likely part of a chronic pain pattern. But I will also confess that, especially on young people, I'm not treating the spine very much. I might be a lone wolf on this one, but I don't always treat the spine. I'm not actually worried about the spine unless I see something not getting better and it becomes a bilateral issue. Right now I'm working a lot of college athletes. I'm not treating their spine most of the time. I'm treating their joint function. I'm improving their joint function. So I'm putting it out there. It's not always long-term success when you're just treating pain. You have to think about function. And then again, also what I would say is, if there was a spinal compression, you do need to address it. It does need to be corrected. But then you're still going to have to go back to the joints in trouble and fix the function of the joint. So whether there is a spinal compression or there isn't, you're always going to be looking at treating mobility and joint function for whatever joint is in trouble. So, okay. That's it for today, and have a great week.